Maybe we can start. It's 3 minutes past 12. So for this noon, we'll be looking at the evidence regarding the use of filter. This is one of the most common procedure that we do. And in fact, when our when our resident graduate from a program, this is one of the skills that they acquire because we do a lot of filters. At the same time, we let them do the filters. They don't have to go into fellowship to learn a filter placement. So to understand the use, let's look at the background. Embolism is a common condition. About 570,000 to 600,000 new cases per year. So that's a large number of PE per year. It's potentially fatal. When you look at mortality, it's 13% at 30 days, 26% at 1 year, and very high at 3 years, 35.3%. And the death is as high as 200,000 per year. And in fact, it's one of the most common litigation, especially in the field of OBGYN, among pregnant or postpartum cases. So it's one of the most common cause of litigation. And then not only that, it's one of the most common cause of medical errors among the top 12. Most emboli come from lower extremity or pelvic vein in 80%, and emboli from upper extremity is only about 10 to 15%. It is related to the use of central lines. And the risk of PE from DVT is unknown, but that's the same. We protect them from the development of PE. It ranges from 6% to 60%, depending on the series that you review, and it depends on the treatment given. It depends on the size and the shape of the thrombus. And the cornerstone of treatment is still anticoagulation, and filters are recommended for these two major indications. If there are contraindications to anticoagulation, and number 2, failure of anticoagulation. Historically, the things that we did in the past is the surgical ligation in 1962 to 1964, but the mortality was 10 to 15%. And then in 1967, the first Cava filter was introduced. It's called the Mobian filter. It's like a partially open umbrella, but it's more solid than the filter that we have today. There are perforations. You could just imagine that the caval occlusion is as high as 70%. And then we were happy in 1973. The first Greenfield filter was introduced. But the problem at that time, it has to be placed through a venotomy. So it was done initially by the surgeon. In fact, Dr. Greenfield is a vascular surgeon, so that's the one who did the first acceptable filter. And then in 1984, Castañeda described the first percutaneous placement of the Greenfield filter. Then currently, we have more than 6 filters in the market. So we have these different forms of DVT. It could be iliofemoral. It could be femoropopliteal. It could be cuff vessels. But the ultimate aim of your patient treatment is just to prevent the pulmonary embolism from occurring, migration of this thrombi into the lung. And therefore, this is the idea of placement of a filter. You're able to catch the thrombus before it goes into the lungs and causing a potentially fatal pulmonary embolism. This is the Greenfield, so let's take a look at the prototype. This is the basis of all the design of the filters. It is a partially open umbrella. There are 6 legs, and there is a hook at the base of the leg that will partially hook into the wall of the IVC. And this is at the apex. You will see this is the reason why, because of the laminar flow of the blood, the clot are trapped as they go upstream into the apex of the filter. And let's take a look at one leg. And the reason why this is designed like this, it will still not impair the flow. There are some angulations just to improve the flow, to improve the laminar flow through the filter. So let's take a look at the particular case in here. So with the cablegram is done, you would see that there is a large clot in the lower part of the IVC. So your goal is to place your filter above the clot. So you measure the distance, and the distance is just enough for you to place the filter above the clot. And that is the level of the renal vein. So you can still place the filter below the level of the renal vein, and that's the proximal part of the clot. And a Venatech filter has been placed, and you would see that the apex of the filter is just placed at the inflow of the lower lower renal vein, which is the right side. That is the apex of the filter. And this is the Vena. This is one of the second generation of filters after the first generation, which is the Greenfield. It maintains the basic design of the umbrella, but in addition to the basic design of the umbrella, there are stabilizing legs that are opposing against the wall of the IVC. The other second generation filters are the Simon-Nightingale. It's nitinol. Nitinol is kind of metal that has a memory. At a certain temperature below the temperature of the blood, the human blood, it is malleable, meaning soft. And then when you deploy it into the IVC, it becomes warm up to the normal temperature of the blood, and then it becomes hardened. But it still maintains the shape that the shape that it assumed the time that it was packaged in the manufacturing company. So it is a memory, and then it becomes hardened and more stiff when it is warmed up to the temperature of the human blood. There are two filter levels, the mushroom at the upper part and the basic umbrella design at the lower part. Similar to the Greenfield, you will see hooks at the base of the filter. Then among the second generation is the bird's nest filter, because the problem with other filters is that you cannot place them in Cava that are greater than 28 at the time, until there was the trapeze. The trapeze was slightly increased to about 30 millimeters. The trapeze is one among the third generation of the filters. So this could be placed in a Cava that is larger than 30, as long as within 40 millimeters. But the problem with this one is the process is 7 steps. And in fact, we don't place them very common, so every time we place them in the past, we review the steps. So there is a nest, and the nests are held by 2 anchors. We have a proximal anchor, a distal anchor, and then the nest of the wire. The problem with this is that you cannot really control the deployment of the nest. Sometimes with the flow, they can prolapse into the right atrium, especially if you place them suprarenal. So as much as possible, you should not place them suprarenal, because with the flow, the nest, the wire, they could prolapse into the right atrium. Then they're still being used. The counter tulip, it comes with the transfemoral. It is preloaded. This is the first retrievable filter in the market. There is a hook at the apex where you can retrieve it with a snare. And the other one is the transjugular. And the transjugular, you have to do some assembly before you place it into the IVC. You have to assemble it. The femoral is pre-assembled. Then the trapeze is the one we are more familiar with. So the difference between the trapeze and the optis is that you will see there are 2 sets of hooks, the proximal hook and the distal hook, and there is no hook at the trailing end of the lantern type of the filter. In contrast, you would see the optis. There is only 1 set. You don't have the distal set, but in addition to the distal, aside from the distal set, in lieu of the distal set, you have a hook that you can snare. The reason being is that when you snare in here, you engage the hook and put your large seat, a 10 French seat in here. This will collapse along the direction of the seat that you're using to capture the filter. And the trapeze, the direction of the hook is directed against the direction of which you will place the capturing introducer seat when you collapse the filter for retrieval. Indications. So contraindication for anticoagulation must commonly have trauma, active bleeding, complications of anticoagulation, failure of anticoagulation, prophylactic, especially among trauma patients, and a free-floating thrombi in the IVC or in the iliac vein. And indications commonly are contraindication. Anticoagulation would constitute the lion's share, about 23 to 70%. Then second is the complications of anticoagulation, about 27%. Failure of anticoagulation ranges from 4 to 50%. prophylaxis, it could be as high as 30%. When you look at recommendations and look at the level 1, level 2, and level 3, meaning level 1, we don't have time to discuss the definition of level 1, level 2, level 3, but for examination purposes, just read them by yourselves. For level 1 recommendation, routine use is not performed, or prophylactic IVC filter. They discourage routine use of prophylactic IVC filter placement. And then another level 1 recommendation is routine IVC filter placements is not indicated in patients with DVT who can be anticoagulated. The level 2 recommendation, IVC filter is indicated in patients with proximal DVT who cannot be anticoagulated. But even in the presence of the filter, this patient should be anticoagulated once the bleeding resolves. So that should not be an issue. It's a recommendation of all the societies that are concerned with IVC filter placement, that even though a filter has been placed in somebody with a DVT, once the risk of bleeding resolves, then the patient should be placed on anticoagulation. Temporary filters may be considered when the risk of PE or contraindications to anticoagulation is anticipated to be less than 2 weeks. And there are no level 3 recommendations. Then similarly, when you look at the extensive, the extensive or the expanded indications of the Eastern Association for the Surgery of Trauma, this was published initially in 2001. It has not been revised recently. So very similar. A level 1 is a recurrent P despite anticoagulation. Another level 1, contraindications for anticoagulation. Another level 1, major bleeding while anticoagulation is being actively administered. And another level 1 indication is progression of iliofemoral clot despite anticoagulation. The level 2, large free-floating thrombus. And then another level 2 is following massive PE in recurrent emboli, which may prove fatal. We get a lot of this from ICU. Somebody with massive PE, then they come down to us for, aside from thrombolysis, they come down to us for the placement of filter. Because the reason being is that you already have compromised the vascular bed capacity with the massive PE. They will not be able to tolerate another showers of PE. That's the reason why. And prophylactic filters, these are level 3. Somebody who cannot receive anticoagulation because of increased bleeding risk and have one or more of the following: GCS score of less than 8, incomplete spinal cord injury with paraplegia or quadriplegia, complex pelvic fracture associated with long bone fractures, and multiple long bone fractures. Then similar, we don't have to go over them, similar from the clinical practice guidelines, the 8th edition of the American College of Chest Physicians, and also similar in the recent division of the 9th edition of the guideline, very similar level of indications. We don't have to review them. What are the contraindications? Uncorrected coagulopathy, that should not be a problem. We can always give blood transfusion. And systemic infection with bacteremia, I think it's not this is just a relative contraindication. You can give antibiotics and treat the sepsis. When you look at the filters, there are some differences in the performance. You would see that, trapeze, they said that the problem with its migration, they said that bird's nest is the cheapest. And then, of course, the greenfield filter, especially the one that goes over a wire, is one of the advantages because you can align it and you can diminish the amount of tilting, because they claim that tilting of the filter will diminish its filtering capacity. There is only, are the filters equal? There are only one study, randomized clinical trial, that addressed that issue, but unfortunately, it only compared the greenfield. You can call it the standard, the basis of other filters for comparison. When the trapeze was compared with the greenfield filter in a randomized clinical study, these are the results. They have shown that with IVC and intravenous thrombosis, it is high with trapeze, about 7%. But in terms of filter migration, in terms of access site thrombosis, misplacement, and IVC perforation, there's no significant difference because both of them registered 0 prevalence of the above-mentioned complications. What are the results? Successful deployment, 99%, that is the threshold. Post-filter recurrent PE, despite IVC filter, the threshold is 5%. Complications, major, less than 1%. Access site thrombosis, 2%. These are the threshold given by the society. Caval thrombosis, 5%. Filter fracture, very low, 1%. Filter migration, less than 1%. Filter infection, less than 1%. 30-day mortality due to the filter, less than 1%. And 30-day mortality due to concurrent conditions, comorbidities, is 17%. This is a picture of misplacement. You would see that if you're not careful, you could misplace it into the renal vein. Another one, a tilting that is misplaced and then causing some injury into the liver. And the filter tilting is insufficient protection. This one is tilted initially, and then the filter was placed in a higher location, a better aligned filter. And then extreme complications, caval perforation with large hematoma and caval thrombosis. Is this a complication, or is this an evidence that the filter is just doing its job? It could be viewed other way. Some examples of thrombi, large thrombi. You see the filter there. Another one, large thrombi. You see the filter, large thrombi. Then you could see the bird's nest filter. Now let's go to the evidence. Are the filters effective? When you look at the evidence, it's just one of the triad. The triad is it's like a Venn diagram. It's just one of the aspects of the evidence. Look at the clinical expertise. Look at the patient value. Empower your patient. Let the patient decide. Don't decide for your patient. Empower them. Let them make the decision themselves, especially if you're offering a treatment that the margin between benefit and risk is very narrow, or you're comparing treatment A, B, C, and D, and the differences are not very, very high, so you have to empower them. They have to decide. How do we empower them? There is a good decision aid. This is from the Ottawa University. They call it the Patient Decision Guide. It's quite comprehensive, but I tried this in a few patients, especially the first I tried this in a pediatric case that was referred to us, to our service, for catheter-directed thrombolytic treatment of a DVT. So there's a high risk for bleeding complications, especially intracranial bleed. So what I did is that I did not decide for the patient, so I went to the room and used this patient decision guide and let the patient decide. I left them for 1 hour, then filled up this one, and then had a short conference with them. So we don't have the time to look at this, but it empowers the patient to make the decision themselves. And if you're interested, this is the link to that. So if your question is an intervention, what will be the study that you are reviewing? First, it should be a randomized clinical trial. If you are studying etiology and risk factors, it should be a cohort or case-controlled study. Diagnosis is cross-sectional study. Prognosis, incidence is a cohort study. Prevalence, cross-sectional study. Experiences and meaning, qualitative study. So intervention, you have to look at a randomized clinical trial. This is the cascade that we use when we're looking at evidence for intervention. First, look at the Cochrane library. This is their Cochrane systematic review. If there's none, then you have to go to DARE. DARE is Database of Abstract Review of Effectiveness. If there are no systematic review, then you have to go to Central Register of Controlled Trials. And then if there are none, then you have to go to the clinical queries of the PubMed. Don't go initially to PubMed. You have to go through the highest evidence. The highest evidence are given by Cochrane in the form of systematic review or meta-analysis. That's the reason why the logo of the Cochrane collaboration is what? It's the forest plot. Yeah, the forest plot. Yeah, it is the forest plot. The forest plot is for meta-analysis. So evidence pyramid, so the lowest is animal research in vitro study. Then the second lowest is expert opinion. Then followed by case series and case report, case control study, cohort, randomized clinical trial, then systematic review. The highest in the evidence pyramid is meta-analysis. Let's take a look at the evidence in the use of filters. Let's take a look at case series. Let's look at the randomized clinical trials. This is the PREPIC. This is the study in France. It is a multi-center study involving 44 centers. the publication in 2005. It's an 8-year study. So far, this is the best study. This is the best evidence for the use of filters. 8-year study follow-up. A population-based cohort study by the California Discharge Data Set. This is the large study, so many thousands. Then the highest evidence is the systematic review. Let's look at the case series. The case series, when you look at pulmonary embolism, the incidence is 2.7 to 3.6%. Fatal P is 0.3 to 1.8%. DVT is as high as 32%. Insertion site thrombosis is as high as 15% or 16%. IVC thrombosis is 3 to 10%. And post-thrombophlebitic syndrome is as high as 41%. Let's take a look at the PREPIC. The PREPIC is just a abbreviation of the French title of the study. So there were 400 patients enrolled with DVT with or without PE. So the common problem was DVT with or without PE. And they were randomized into 2 groups, 200 with filter, the other 200 without filter. The only problem with this, they were anticoagulated during the first 3 months, at least 3 months. But both received anticoagulation. And then they were followed up for a period of 8 years. They were followed up at 3 months, and then 1 year, then every year until 8 years. So they were able to complete 8-year follow-up. When we do appraisal, a randomized clinical trial, this is how we do appraisal. This is from the publication of the Evidence-Based Medicine Center. So number 1 is, are the results of the trial valid? Meaning, what question did the study ask? So regarding question, it could be summarized into the acronym PICO, meaning patient, intervention, comparison, and outcome. So it's PICO. So you have to reduce the question into PICO. So the patient is DVT with or without pulmonary embolism. The intervention that you are studying is the IVC filter placement. Comparison is no filter. And the outcomes that you are measuring are pulmonary embolism, mortality, and DVT. And then the second question, was the assignment randomized? So you should see that in the study design, and according to this, it was randomized. And then the next question now, were the groups similar to at the start of the trial? Why do we have to know this? Jared? Very good. So you have to eliminate possible confounding variables, because if there is a significant difference between the baseline characteristic of one group and the other group, you cannot be sure if the outcome that you are seeing are the results of the treatment, or was it influenced largely by the confounding variable. So ideally, they should place a p-value, meaning there's no significant difference between the characteristic between filter group and the filter group. But overall, when you eyeball the figures, in terms of the demographic, there should be no large differences between the 2 groups, filter group and no filter group. But ideally, there should be a p-value on the third column. Aside from treatment allocation, were the groups treated equally? Yes, because all of them received vitamin K antagonists for at least 3 months, both groups. Then the filters that they used were 4. They used a Vena filter, they used a Greenfield, they used the BARD, and they used the bird's nest. Is there a clinical implication of this regarding to the outcome? With regards to the outcome. Remember that they did not use uniformly the same filter. Is there a significant difference in the performance or complications of the filters? They did not even mention that, how many received this particular filter in one group and the other group. So when you look at performance of filters, the problem with Greenfield filter occlusion, IVC occlusion 12%, the bird's nest is higher, as high as 15%. The simonitinol is 20%, because one of the outcomes that we're looking is IVC thrombosis, or DVT. And then the Vena tech filter is high, 60%. Trapeze is lower at 8%. And then the next question is, were all patients accounted for? So you have to look at the follow-up. And as a guide, the loss to follow-up should be minimal, preferably less than 20%. And then there should be intention to treat. What is intention to treat, Simon?
That if the patient does have DVT, that you plan on giving the thrombolytic or anticoagulation.
Yeah. Even if they drop out from the study, they fail to follow up, analyze their data into the original group to where they are assigned. That's what we call intention to treat. And then this is study. The follow-up rate was very high, 99%. The dropout rate is just 1%. This is a good study in terms of follow-up. Then were the measures objective and were the clinicians kept blinded? Yes, they were. When you look at this one, the members of the research team were unaware of the treatment assignment, so they were blinded as to which treatment group. So this is the you can download this from the evidence-based center. This is how you appraise a study and randomized clinical trial or clinical trial. Then the second group of questions: how large was the treatment effect? Then how precise was the estimate of the treatment effect? Let's take a look at the results of the PREPIC study. When you look at symptomatic pulmonary embolism, there was a clear difference between the filter group and the non-filter group. The p-value is 0.008. When you look at DVT or recurrent DVT, also the difference between the two groups is 0.042, which is less than 0.05, being more common among the filter group. And then post-thrombotic syndrome, there's no significant difference between the two groups. And mortality and major bleeding, there's no significant difference between the two groups, the p-value being more than 0.5. When you look at pulmonary embolism, you would see that over time, as you follow it from zero year to 8 years, you would see the clear separation between the two groups. Over time, there is a clear advantage of using the filter regarding prevention of pulmonary embolism. How about DVT? You will see also over time there is a clear difference between the two groups, meaning the DVT is more common among the filter group compared to the no filter group. And in terms of mortality, you would see that there is no significant difference between the mortality of the two. The graph lines, the survival line overlaps all throughout the years. When you look at mortality, the mortality was mostly related to non-pulmonary embolism. Cardiovascular in origin, cardiac disease, and bleeding are among the most common causes. And when you look at pulmonary embolism as the direct cause of the mortality, only about 1.8%. So how do we measure the effect of therapy? Let's take a look at non-fatal PE. So let's take a look at the risk without filter. Let's compare the risk with filter. Let's designate them as X and Y, respectively. So the risk of without filter, based on the data that I have shown you a while ago, it's 9.5%. With filter, the risk of non-fatal PE is 3.5%. Then when you compute for the absolute risk reduction, it's just the risk difference between the two. The risk reduction is 6%. When you look at the relative risk, it's just a ratio between no treatment and treatment. You would see that the relative risk is 0.368. When you look at the relative risk reduction, meaning the risk reduction in relation to the control group, you would see that it's about 63%. And then numbers needed to treat is 16.7%. Why do you have to look at the NNT? Just like, what's a clear-cut example of this one? The more controversial one. Mammogram, yeah, mammogram, yeah. It clearly shows that screening mammogram reduces mortality of women, included in the screening group. When you compute for the numbers needed to screen, it was 2,000. They computed for, and then they computed for the cost of saving one life, and it was enormous. That's the reason why there was a disagreement between the radiology group and that group of the prevention group initially. I don't know if they've reconciled the differences.
What was the anticoagulation status of these two groups again?
Only for 3 months. Only for 3 months. Only for 3 months. Very similar in both groups. What is the relative risk? It is just a risk of outcome in the treatment group divided by the risk of outcome in the control group. So a ratio of 1 means there's no difference. To be significant, the RR should be less than 1. And in this particular case, the RR is 0.368, so it's less than 1. So filter placement decreases the risk of non-fatal PE. The absolute risk reduction is the risk of outcome in the control group minus the risk of outcome in the treatment group. So, this is an absolute difference in the rates between the two groups. It gives you an indication of the baseline risk and the treatment effect. So in this particular case, it was 6%. And the relative risk reduction is absolute risk reduction divided by risk of outcome in the control group. So the difference in relation to the risk of outcome in the non-treatment group. And what is the advantage of this one? Simon.
Seems like a comparative measure.
When you look at the filter here, look at this one. Absolute risk reduction versus relative risk reduction. This is the very same reason why pharmaceutical industries, when they give you a promotional brochure or promotional leaflet, they use the relative risk reduction. They do not specify that. They just tell you it reduces or improves treatment by 63% or 50%. They don't tell you the absolute risk reduction. Why? It's more pleasing to look at 6%. It's more pleasing to look at 63% than looking at 6%. But they don't specify if it is a relative risk reduction or absolute risk reduction. So if you are being covered by a med rep, ask them, is that the relative risk reduction or is that the absolute risk reduction? Because it's more pleasing to look at 63% compared to looking at 6%. And then the numbers needed to treat is, yes, we need to place filter in 16 to 17 patients in order to prevent one non-fatal PE. Is this cost effective? Maybe it's just 16 to 17. You have to treat only 16 to 17 just to save one non-fatal PE. How about fatal PE? Without filters, 2.5%. With filters, 1%. The absolute risk reduction is 1.5%. And then when you look at the relative risk reduction, it's 60%. Then you would see the clear significance between the difference between our relative risk reduction and absolute risk reduction. 60% is better than 1.5%. When you look at the numbers needed to treat, it's 66.7%. That's still, I would say, it's still cost effective. It's just you have to place filter in about 67 in order to prevent one fatal pulmonary emboli. But you should incorporate the adverse effect with the numbers needed to treat. This is the way to do it. What is the adverse effect that you don't want? Incidence of recurrent DVT. And among the population, the incidence was 28.5% in the filter group. When you are looking at the numbers needed to treat for prevention of non-fatal PE, 16.7, or prevention of one fatal PE, 66.7. If you have to incorporate NNT and incidence of recurrent DVT, the numbers of recurrent DVT that you incur per one non-fatal PE prevented, just multiply the two, 4.8. So I am preventing one non-fatal PE, but in the process, I am causing DVT in 5 patients. That's the way to look at it. How about the fatal pulmonary embolism prevented? Meaning, for every fatal PE I prevent, for every patient I save from dying from PE, I'm causing DVT in 19 patients. It's still, I think, still cost effective. Will the results help me in caring for my patients? So you have to ask the question. You have to look at the study. Is my patient similar to the population that was included in the study? Otherwise, I cannot make use of the results. Will the potential benefits of treatment outweigh the potential harm of the treatment for my patients? So these are the questions. Look at the population. Is your particular case similar to the population that they included in their study? This is the another large question, another significant question. How about trauma? Yeah, we put them a lot in this institution. It's a very common indication. This is the highest evidence so far. A systematic review of the effectiveness of prophylactic IVC filter placement in trauma. It's a large research. They started with Medline and all the what included here. They started with 37,000 possible articles. About 2,194 they did it manually, and then they were able to look at a lot of duplicates, and then from there on they were able to eliminate 20,687. Just to cut short the cascade of how they did it, and eventually after a lot of exclusion, they were able to come up with 8 controlled studies. 1 randomized clinical trial, the 7 were controlled observational studies. There's only 1 RCT. The other 7 are controlled observational study. When you look at the studies that are included in here, as I have said, 1 was a randomized clinical trial, the other 3 were prospective cohort, the other 4 were historical comparison. And then when you look at the baseline characteristic, they did not put the p-value, but overall you would see that this group, at least eyeballing it, there's no significant difference between the injury severity score in the filter group and the non-filter group, but the rest did not. Did not report it. Did not report, especially this study here. But overall, the one which reported the ISS, you would see that eyeballing it, there's no significant difference. Only for this one, the second study. So let's take a look at the forest plot. The relative risk of pulmonary embolism, including fatal and non-fatal, with the use of filter in trauma. You would see that in the filter group, the incidence of P is 0.6% versus 6.58% in the non-filter group. When you look at the pooled effect, it clearly favors IVC filter placement. The diamond is clearly favors IVC filter. It doesn't touch the line of no effect. Similarly, when you look at fatal pulmonary embolism as your outcome, the filter group 0 versus 4.9% in the non-filter group. When you look at the diamond clearly favors IVC filter and doesn't touch the line of no effect. How about DVT? You would see that with filters, 16%, without filters, about 12%. But when you look at the pooled effect, the diamond overlaps the line of no effect, so there's no significant difference between the two. How about mortality? Mortality in the filter group is 12.7%. Mortality in the no filter group is 19%. Eyeballing, this seems to be an advantage of the filter group, but when you look at the pooled effect, using the forest plot, the diamond overlaps the line of no effect, so there's no clear-cut difference. It doesn't favor filter, nor favor no filter. So when you look at the measures of outcome again in IVC filter in trauma based on this study, the risk of pulmonary embolism, fatal and unfatal included. Without filters, 6.58%. With filter, it is 6%. When you look at the absolute risk reduction is 5.98%. It's almost 6%. And when you look at the relative risk reduction, it's very high, 91%. When you look at numbers needed to treat, 16.72%. How about fatal PE? The risk without filters, 4.9%. The risk with filters, 0%. And therefore, the absolute risk reduction is 4.9%. The relative risk is 0. And therefore, the relative risk reduction is 100%. When you look at numbers needed to treat, it's 20.4%. When you incorporate the adverse effect and the NNT, based on this one, the incidence of DVT in the filter group was 16.07%. And then incorporate NNT per 1 PE prevented and NNT per 1 fatal PE prevented, you come up with this computation. For 1 PE prevented, I would cause recurrent DVT in about 3 patients when I prophylactically place a filter in somebody with trauma. And if I have to place a filter and my aim is to prevent fatal PE, for every life that I save from dying from fatal pulmonary embolism, I would have caused about DVT in about 3 to 4 patients. So it's not the combination of the adverse effect and NNT it's very favorable to just 3%. Meaning 3, absolute number. 3. However, when you look at the data from that particular study, when they did a different computation of the NNT and base it on a published baseline rate, you would see that the NNT is very high. For PE, it was as high as 962. For fatal PE, it's as high as 1,099. When we do a computation based on this one, incorporate DVT with this one, you come up with this computation. For every pulmonary embolism that you prevent, you would cause DVT in 154 cases. And for 1 fatal PE that you prevent, you would have caused DVT in 177 cases. Still not bad. But look at the quality of the study. According to this, the bias is high. So I think we have 10 minutes to finish this. The large studies, again, the California discharge data set is the largest one. They had included about 3,632 filter group and about 64,000 no filter group, control group. When you look at the results, 1 year relative risk of rehospitalization for PE was not reduced by filter placement compared to the control, regardless of whether they had an initial diagnosis of DVT or PE and 1 or no previous hospitalization for VTE. So 1 year, the relative risk of hospitalization for PE is not significantly different between the 2 groups. And in the group with no previous hospitalization for VTE with an initial diagnosis of PE, the relative hazard for readmission for PE was slightly higher among the filter recipients. It's even the opposite. Recurrent PE occurred primarily in the first 3 months, and filter recipients who initially suffered PE were at higher risk for the development of DVT. So the best evidence, so far so weak. Filter reduced the short-term incidence of total PE among patients with acute proximal DVT at the expense of greater risk for recurrent DVT. Only exists when symptomatic and asymptomatic events are counted. And these population-based studies support the data, the concept that filters do not significantly reduce symptomatic PE. Do they provide protection against PE more than standard anticoagulation? There is no RCT that addressed this question. The PREPIC study, they were anticoagulated for 3 months. The population-based study that we reviewed from California, there was no information on anticoagulation. One study addressed this question. It was an old study that was published in 1994. It is a prospective unrandomized case series of 63 patients. There was no difference in the thrombotic outcomes between the filter recipient and the patients on anticoagulation, so there's no difference. We look at the Cochrane collaboration, so this is the logo. The logo is the forest plot. So there were two included in here. The first one was the PREPIC study, and the other one was an old study in 1974 regarding prophylactic IVC filter placement in hip fractures. We already have reviewed the PREPIC study, but when you look at the second study, you would see in here that clearly there is less incidence of pulmonary embolism among the filter group, 10% total for IVC filter group, and the control group is about 32%. When you look at mortality in the filter group, mortality in the filter group is 10%, in contrast to the 24% that was registered for the control patients without the filter. But based on the conclusions that was drawn from the two study by the Cochrane collaboration, the PREPIC study lacked statistical power to detect reduction in PE over a short period of time and more clinically relevant time period. Filters were associated with increased risk of long-term lower limb DVT. There's positive outcome evidence when used within currently approved indications. It was just general indication. It was not subsidized to the different indications that we use. And therefore, further trials are needed to assess safety in the different subsets. And these are not my words, so don't throw tomatoes at me. This is a BMJ editorial. According to the BMJ editorial, only about 15% of medical interventions are supported by solid scientific evidence. And during the time that arguments for and against Obamacare was very active in the TV show, and there was a health outrage of the week. I don't know what year was this. And they said at that time that because of the data, that it's solid evidence in about 15% or 20%, this would put about 80 to 90% of accepted medical procedures in this country under the heading of quackery. These are not my words. But I will bring you again to a different concept, because evidence-based medicine is hooked on statistically significant difference. But there is the concept of minimum clinically important difference. And what is this? It is the smallest change in the outcome that the patient would identify as important, meaning you empower your patient, present them the data. The treatment outcomes not significant difference, but there is a difference. At what difference would you accept this treatment? That is one way of doing the MCID. Another way of doing it is statistically. You have to reduce the clinical significance measurement, meaning just one half of the standard deviation, or one half of the standard error of deviation. They have made some adjustment, or they can make it by a Delphi conference, wherein there is a voting. The audience, the experts vote as to what is a statistically significant difference that has to be considered. With this in mind, I hope I have given you an unbiased presentation, but overall, the evidence is weak. But still, we have to do it, because we still have to look at it from the point of view of minimum clinically important difference. Any question? That's the last slide.